So I'm going to do a demonstration with one of you who's going to volunteer, hopefully, sitting on this chair in a minute, but the microphone is here, so that's why I'm sitting here. So I'll talk about the 60-second neurological examination. Actually, before I do that, I'll tell you about it. So we've talked a lot about history and localizing, and then you do your examination. And you're busy, you have only 10 minutes for your patient perhaps, and then you have somebody with a neurological complaint and your heart sinks, and it's like, oh my God, now I have to do this whole neurological examination. And so of course you're going to do a focused examination. So I don't do an hour-long examination ever. Nothing ever takes me an hour when I do a neurological examination. So I also do focused examination. So if somebody has an arm problem, I will look at the arm. But you cannot stop there. You do need to look at the rest of the nervous system, because while the arm seems quite far away from the leg, in the brainstem, they're actually really near one another. And while sensation in the arm, in the left arm, may seem really kind of remote to sensation in the right leg, if you have a spinal cord lesion and you have those split sensory fibers affected, you might get some problems in the opposite leg to a different modality. So you need to just at least be aware that just looking at the cranial nerves, or just looking at the upper limbs, or just looking at the lower limbs, you do risk missing something. And I want to really stress that, because when we're taught the neurological examination in New Zealand, we always ask to split things into cranial nerves, upper limbs and lower limbs, right? That's how you were taught in medical school. You do your OSCE and you say, now please examine the upper limbs. And it really bothers me, because it does not do the patient justice. And we're not an examination situation, and you want to have a glance at the whole nervous system, because otherwise you will miss things, especially things that the patient may not have noticed themselves. So you want to ideally bracket the abnormality with normality. So you want to find all the normal things, so you can really hone in on just the area that is abnormal, and you move out neuroanatomically, if you will, to where you have that normalcy, so you can define that lesion. Just like you might, if somebody has thigh numbness, you take a pen and you map out your sensory patch. You might do it with a pen and draw the little oval shape for a supraephemoral nerve lesion that you might get. And so just imagine that in the neuraxis, in your nervous system, you want to do that, except you don't get to go in with a pen. You need to do your neurological examination. So what I'm going to show you, I'm not going to spend time on detailed examination on any part, because you've learned that in medical school, and you deep in your temporal lobes, you'll remember what all the cranial nerves are, and in a pinch you'll be able to pull that out. What I'm going to show you is the screening neurologic examination that I recommend you do with anyone who comes in with a neurological complaint, to screen for some abnormalities you may not have picked up in the history. Does that make sense? So that's what this 60-second neurologic exam is about. So now I'm just going to, can I just do this so I can see it? So when I think of the neurological examination, rather than grouping it by head, arms, and legs, I think of it as a neurological system. So I think of the mental status examination, I think of the cranial nerve examination, the motor examination, sensory, coordination, reflexes, and gait. So those are the components of the neurological system. If you examine all of those things, you've gotten a pretty good flavor of what's going on. It sounds like a lot, but it can be done pretty quickly. And so I think of them not so much by limbs, but by fiber type, if you will. And if you remember our localization, that's sort of how we think about the nervous system. Now, so what I'll do is I'll walk you through these things, and then I'll show you, in fact, maybe I'll get my volunteer. So the first thing is the mental status examination. Now, most people who come into your surgery will have a normal mental status examination. They're not acutely comatose. Those are a little bit different. This is not what I'm doing now. You've just interviewed them, right? So during the interview, you can basically tell the entire wellness of somebody's cognition. They've just told you when their symptoms came on, they've described them, they've told you about the environment around it, so you get a sense that they're orientated to time, they were oriented to the location that they've done it, the situation, and people around them. So, and you've assessed their language. They've just told you about their symptoms. You've asked them questions, so they've responded. You know that they can understand what you're saying because they've responded to your questions. So unless I pick something up in the history that makes me concerned about language problems or cognition problems, or they come in with a primary complaint about language or dementia, memory complaints, I will not do anything further on that. So I do not ask them, I haven't just, Kino's just told me all about her condition. I'm not going to ask her now, do you know where you're at? She's just driven herself to your surgery. She knows where we're at. She's looked at the address. She's come here a million times. So that's not necessary, right? But you've done it. So it's not that you haven't done it. You've done it, and you've ticked that box. So then the next thing is cranial nerves. So cranial nerves, you've also already done some things. You've watched them talk. Right? So you've observed during the conversation the movement of their mouth, you've listened for dysarthria, and you may have looked for upper facial droop. But there's a couple things you haven't done, and the things that are most important to not miss is visual fields and extraocular motility. So what I do is I ask the patient to look at my nose. How many fingers do you see altogether? 4. Okay. So what I've done there is I've checked her visual fields. It's a screening visual field examination. If she hadn't gotten that right, I would cover an eye and do, map out the field. But for a screening test, it's all you need to do. And what you do is you place yourself, sort of an arm's length from the patient, right across, and then you put your fingers equidistant between her nose and my nose, and kind of where I can just barely see them. So I can see the 2, but it's not very easy for me. But you see all 4 here. Yeah. If I go there, it's already getting a little difficult. Mm-hmm. Yeah. And here it's pretty obvious, right? So you can use yourself as the control. You practice that with somebody, and it's a really good little test for peripheral field. On top of that, I've checked her math skills. She can. It sounds silly, but 2 + 2, and it's a sort of a complex command. You ask, they've never done that before. That's a bit of an odd thing to ask somebody to do. You kind of, how quickly can they comply with that? And you've asked for inattention, because you've presented them with 2 objects in their visual field at the same time. So this is the problem when you map out one eye at a time. You're not checking for neglect. Right? Neglect is when there's a visual neglect. You know what I'm talking about? So you're presenting 2 objects at the same time. They may have full visual fields and see it over there and see it over there. If you do both, they only see one side. Because presented with 2 objects at the same time, they will neglect the side that is abnormal. So that's your right MCA stroke syndrome, where you have this neglect of the left side. So while I have my hands up, I'll then move to extraocular motility. So what I do is I look at my nose, and most patients are not trying to fool you, So you learn how you close your eyes to do sensation, and so I'm trying to be quick. I'm not trying to make it too hard. So I say, do you see all 4 fingers, or how many fingers do you see all together? So if they need a little prompting, I just give them yes/no things. It's not as sensitive as if I give them a really complex thing, but it gets me through it a little bit quicker. So I might say, how many fingers do you see, or do you see all 4 fingers? Yes?
Yes.
And then I say, do you see 1 finger here?
Yes.
Now follow my finger with your eyes. Do you see 1 there, 1 there, 1 over here, and here? And I've checked for diplopia. Okay, and I'll just do that while I have my fingers up there, all in one go. So that's pretty much all I do for cranial nerves. Okay, so you've checked your brainstem, because your midbrain, you've done extraocular motility, you've checked cranial nerve 1 and occipital lobes, and you've checked pons, because then they don't have a facial droop, and you've checked the medulla because they're not dysarthric, because you've gotten that during the interview, right? So you've done a really nice little screen of your cranial nerves. This is all assuming all of this is normal, right? It's your screening. If anything is abnormal, you have to explore further. Okay, so then moving to the motor examination. So what I have people do is, can you lift up your arms like this and turn your palms up? and then close your eyes. Okay, so you can open your eyes. Put them down for a second. So what that tests is a very sensitive test for mostly pyramidal, but really any upper limb weakness. So if you do this for yourself, so the feeling you feel is this thing is kind of hard, isn't it? The pronation is what makes you kind of exhausted, not rather than the lifting. And so when you have a weakness, you do this, right? So that's your pronator drift. So people get that confused. That's not a cerebellar test. Sometimes people conflate the pronator drift with the cerebellar examination because they think the Romberg, right, which is they do this. It has completely different things. So this is a motor test, and it looks for subtle upper limb weakness. And the functional patient will do this, and the truly, organically weak patient will do this. It'll be a subtle kind of thing like that. And if you see that, you then do more upper limb testing. But if they hold it up, hold it up like you're holding a big tray, I say. Hold it up, you don't want to drop anything, and then you close their eyes, and you're also testing a little bit for sensory drift. So if you take your vision out, your arm might kind of do this sort of thing because they no longer know where it is because they may have proprioceptive loss. So you're checking large fiber sensory nerves, and you're checking your motor examination. So then while I have the arms up, you close your eyes, take this finger and touch the tip of your nose, and back out, and that finger, and back out. Okay, and you can open your eyes, sorry. So what we've done here is we've tried sensory examination and cerebellar at the same time. And it's a really good little handy test to do because, again, when you have a functional patient in front of you, you're doing direct testing of that limb that is numb and they cannot feel anything, and you're doing this and they forget that they're not quite sure what you're testing, and you're touching it with their eyes closed. The only way they know that that's the finger you mean is by feeling it. They may have felt numb before, now they feel it. So, you have them do that, and you're doing this a really quick little finger-to-nose test. And then if it looks a little abnormal, I'll have them do a bit more on direct testing. So we've done motor, and we have done a bit of coordination in one go. And then I'll have the patient, I can have the patient sit up. Just stand up. So and just sit back down for a second. So stand up without using your hands. Yeah, so good hip flexion. Right, I've got pretty. So if you can do that, you're not going to be severely weak in the hip flexors. Now you now have the patient standing. Just make sure I'm covering everything. So, and then I'll have the patient stand in place and close your eyes. Now we're doing the Romberg test, and open the eyes. And what have we just tested? We've not just tested the cerebellum. Proprioception, we've just tested posterior column and large fibers in the feet. So we're looking for balance. When you have your eyes open, you can compensate. When you close your eyes, you lose the visual compensation, and you generally need two. You need either the vestibular cerebellar system, the vision, and your dorsal column. So you need a couple to really be balanced, and if you take one out by taking the vision out, you cannot see. If you take the cerebellum out, usually people will be wobbly with their eyes open. So people with cerebellar lesions struggle doing this. People with dorsal column or large fiber neuropathy will close their eyes and do this. And it's positive if they step out of stance. So if they do this sort of thing but hold themselves up, you can say they swayed on Romberg, but it's not actually technically an abnormal Romberg, so they have to step out of stance. And then I'll have people do a tandem gait, walk one foot in front of the other, and that's a really good little screening test for people who are just perfectly normal as far as gait. They're not very sensitive for any very specific test, but it gives you a sense of how they're going. So you've done that, and that really covers your entire nervous system, a little bit from everything. I don't do reflexes routinely as part of the screening examination. I'll do reflexes if there's a motor complaint to compare side by side. But I often get that's often the only sign a GP will put in the letter what the reflexes did, and often isn't that helpful, to be entirely honest. And it's like something you remember to do, and there can be difficult. People have low reflexes for a number of reasons, and they're not technically always easy to get, and they have funny position in one, and you get yourself into a tizzy about it. So if you're differentiating between an upper and a lower motor neuron sign, but then that's your focused area, you're going to check reflexes. Otherwise, it's not usually all that helpful. So let me show you that all in one go. So sit back down. So I've interviewed her, so our mental status is okay. Take a look at my nose. How many fingers do you see altogether?
4.
Do you see one finger here?
Yes.
Follow it with your eyes. One everywhere?
Yes.
Okay, can I get you to lift up your arms like this? Turn your palms up. Close your eyes. With your eyes closed, take this finger, touch the tip of your nose, back out. And that one, back out. And open your eyes and stand up. And close your eyes. And open your eyes and walk one foot in front of the other. Okay, so you cannot tell me that you cannot fit that into a routine GP assessment. Okay? All right, thanks. So I just wanted to tell you a couple more things about functional patients. So we've talked a lot all day about various structural neurological conditions. And functional neurology is a really important part of what we do. So these are patients that we investigate and don't have a structural cause. And in some people consider migraine a functional condition because there's no structural cause usually found. So, it's the definition varies a little bit. Chronic pain can be considered a functional problem. So the main thing that we see is people with functional weakness or pseudo seizures or non-epileptic seizures. Sometimes movement disorders can be functional. So this basically what we're talking about is patients who have a real manifestation of some neurological condition, but we cannot find a structural cause for it. And I just wanted to briefly touch on it. We just recently introduced a medical student lecture on this topic because it's just such a common problem and it's often not managed particularly well. So in general, it's really important to remember that the vast, vast, vast majority of these patients are not malingering. They have a true problem that's causing true disability, and it is a real condition. It's not, and it doesn't help anyone by saying they don't have anything or it's in their head or they're crazy. It doesn't get you any trust from the patient, and it's actually not true. So they do have something that is disabling them, and we need to treat them just like we would treat any other patient. We're just feeling a little bit more helpless because we don't have a structural thing that we can identify and treat. But think about how the patient feels. They're even feeling more helpless. And they're often feeling very disenfranchised from the medical community because they feel not taken seriously. So it's important we take them seriously and treat them with respect and appropriately. So showing empathy and building trust is really important. So you need to believe in yourself that there is a true problem there, and I do believe that. I do believe that these patients have a real condition that needs to be addressed. Now, in order to make a diagnosis, it's not enough to have just normal examinations, because sometimes, like normal investigations, because some conditions will have, like a lot of movement disorders have nothing on imaging or on laboratory testing. So you need to you have to have normal investigations, and then you ideally want some physical manifestation of it being a functional disorder. And this is coming back to your neuroanatomic localization that we went through. So you're looking for things that do not fit into one of those structural localizations. So you're looking for something that doesn't fit an MCA syndrome or a neuropathy or a neuromuscular junction problem or a myopathy. And so I just wanted to run through a couple things that are useful from an examination perspective. So if the patient has numbness, one thing you can do is you can test their sensation across the midline. So when you have your sensory fibers, they actually cross a little bit over. So if you have numbness, if they're numb on the left side, they should be numb to about an inch or so off the midline, because the right-sided fibers will cover that center territory a bit. So they shouldn't be numb straight down the middle, and that's called split the midline. So if you're having a finding where it's, you use your pin and it's dull, 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 and right in the middle becomes sharp, you can document that as the patient splits the midline. And that's not a perfect test for functional numbness, but it's helpful to find that, and it supports the diagnosis. Another thing you can do is you can take a tuning fork and put it on the skull, on the forehead on one side and the other, and you're asking them about the vibration, not the light touch. The vibration is created by vibrating on a bone. It's the same bone because it's the skull bone, so you should feel the same vibration even if you're numb on the other side. So that's another, so they will often report that they're numb to the vibration on the affected side. Another thing is you can put a tuning fork on the sternum and turn it one way and then turn it the other way, but the contact point is the same, and they may feel a difference in the vibration, and then you know that that's not anatomically consistent with the structural problem. There's a couple things on motor examination. I already talked to you about the drift. So the functional drift will often be like this. You just have to be mindful that a sensory drift can look like that, although the sensory drift will be kind of in both directions because it's not weakness. But a functional drift will be down, and often you have the situation where they're holding it up and then they give way. And that's called give way weakness. There's also a bit of a ratchety feel sometimes if they're holding tight and then they give way, and that we also call give way weakness. So a structurally weak limb will have even weakness throughout the course. It can be a little tricky when they have movement disorders and there's a bit of a ratchety or a stiffness, but in a pyramidal weakness it should be pretty even. And then there is the Hoover sign, which is where you have the patient lie down flat on the bed, you put your hand under the good leg, and you ask them to lift the bad leg. And they lift the bad leg, and they cannot lift it. What should happen to the good leg? And somebody who's weak and trying to lift that weak leg. The good leg should push down, right? It goes opposite. And so if you don't feel that, that suggests that there is a functional weakness because there's an effort component. And you can, that's quite a useful little sign. Gait is, so a lot of people with functional ataxia will have quite elaborate gaits, so they'll do this sort of thing. This is quite hard to do, to balance on that one leg, and so that's much harder than not doing that. So there's some, look at the gait and try and fit it into a particular gait pattern. And we already talked about seizures, which are a little bit different. So I think that's really all I wanted to say. I have one slide on specialist referrals and a little plea. We really like to help. If it's a routine problem, it's sometimes easier to just write, and we can write back a letter and then we have it on the system. We're in these acute stroke assessments, and the other day I had a clot retrieval patient. I had 4 GP calls about tension type headache in the middle of trying to interpret advanced CT imaging on a patient who had a time-sensitive emergency. So we don't have so many neurologists that there's one sitting by a phone who just answers calls. So we do all of this at the same time. So we do want to help, but really the calls we would like to be about acute, urgent problems where we need to help that day. Anything that's more routine, just write to us and we can report. And that's nice because then we have a record of that in the system. And I think that's all. So in summary, neurology is really logical. Memorization, at least for me, is nearly as helpful as a simple understanding of anatomy. Once you've localized your lesion, it's much easier to look up a differential diagnosis by Googling it if you're not sure what to do, especially if you've factored in the time course and can narrow it down to a particular disease category. Again, before you do a syndromic allocation, try to force yourself to localize. Most answers are in the history. And when you're concerned, consult pathways. In fact, David's created a wonderful Wellington area headache pathway. And if not, that's not helpful, call us for help. And tell us what we can do to help you. So be in touch.